Hello everyone, I'm Dr. KIRAN Reddy, second year resident, Sri Lakshmanarayana Institute of Medical Sciences. Title of my paper, Role of Color Doppler Ultrasonography in Portal Venous Hypertension. Introduction, portal hypertension is a hemodynamic disorder most commonly associated with chronic liver disease, particularly cirrhosis, though it can also occur in extrahepatic conditions. It contributes to serious complications including ascites, gastroesophageal variceal bleeding, and hepatic encephalopathy, which significantly increase morbidity and mortality. Based on the site of obstruction, portal hypertension can be classified as sinusoidal, pre-sinusoidal, or post-sinusoidal. Early and accurate diagnosis is essential for guiding timely medical or surgical interventions and preventing life-threatening complications. Portal hypertension is characterized by an increase in portal venous pressure. It is variously defined as wedged in hepatic vein pressure or direct portal vein pressure of more than 5 mmHg greater than inferior vena cava pressure. Color Doppler ultrasonography has become the preferred non-invasive imaging modality for assessing portal hypertension. It allows evaluation of portal vein morphology, flow characteristics, and direction, as well as detection of sequelae such as portal vein thrombosis and portosystemic collaterals. Advantages of this technique include wide availability, safety, cost effectiveness, and the ability to monitor disease progression or response to the therapy. Objectives to study the spectrum of ultrasound Doppler findings in portal hypertension, to study the various etiology and complications of portal hypertension, to study and look for presence of various portosystemic collaterals. Materials and method. Patients referred to the Department of Radiodiagnosis with clinically diagnosed case of portal hypertension for a period of 1 year were subjected to study. 50 cases of clinically diagnosed portal hypertension were studied. Each patient was subjected to ultrasound examination using Mindray DC-70 ultrasound machine with curved array transducer. Inclusion criteria: patients with clinical diagnosis of portal hypertension between 25 to 65 years of age, patients with chronic or alcoholic liver disease. Exclusion criteria: hemodynamically unstable patients, pregnant cases, pediatric age group. Parameters assessed are portal vein diameter, portal vein velocity and waveform, portal vein flow direction, portal and splenic vein flow pattern, spleen size, portosystemic collaterals, hepatic vein damping index. Results or analysis are: in 58% of cases, liver is enlarged, and in 56% of cases, portal vein diameter was more than 13 mm, and in 64% of cases, portal vein velocity was less than 16 centimeter per second. In 60% of cases, portal vein shows monophasic waveform. In 90% of cases, there is a hepatopetal flow, and 8% hepatofugal flow was seen. In 58% of cases, portal and splenic vein show sluggish or pulsatile flow, and in 80% of cases, splenomegaly was present, and in 48% of cases, portosystemic collaterals were present. In 60% of cases, ascites is present, and in 38% of cases, had hepatic vein damping index was less than 0.6, and 62% of cases it was more than 0.6. This is an image showing normal portal venous flow and cavernous formation in which portal vein is replaced by multiple tortuous veins. In this image, you can see splenomegaly and perisplenic collaterals and dilated portal vein. Discussion. Portal hypertension is a serious clinical condition, most commonly secondary to cirrhosis, and is associated with significant hemodynamic alterations in the abdominal circulation. Color Doppler ultrasonography, being non-invasive, widely available, and reliable, plays a pivotal role in diagnosing portal hypertension, determining its underlying cause, and identifying complications. Demographics. In the study of 50 patients, most individuals, 47.5%, were aged 51 to 65 years, followed by 37.5% in the 36 to 50 years of age group. Males were commonly affected, 77.5%, and females 22.5%, likely due to higher alcohol-related liver disease in this population. In the study of 50 patients with portal hypertension confirmed by ultrasound and Doppler, 58% had enlarged liver more than 15 centimeters and 42% had normal liver size. Hepatomegaly is commonly associated with early cirrhosis or liver congestion, whereas smaller liver size may indicate advanced parenchymal atrophy. Portal vein diameter more than 13 mm was seen in 56%, while 44% had normal diameter. Reduced portal vein velocity less than 16 cm% was present in 64%, and 60% showed altered monophasic waveforms. Flow direction was hepatopetal in 90%, hepatofugal in 8%, and bidirectional in 2%, reflecting various disease severity and collateral formation. Discussion: assessment of portal and splenic vein flow: sluggish or pulsatile flow in 58% of patients, while 42% had normal continuous flow. Splenomegaly was present in 80%, serving as important indirect marker of portal hypertension. Ascites was seen in 60%, reflecting elevated portal pressure and liver head dysfunction. Portosystemic collaterals appeared in 48% of cases, indicating chronic portal hypertension and compensatory venous pathways. The hepatic vein damping index was elevated, more than 0.6 in 62%, suggesting reduced hepatic compliance, with 38% showing normal values. The results of the study are consistent with previously published literature and support the routine use of Doppler imaging in the clinical management of patients with portal hypertension. Conclusion: our findings demonstrate that color Doppler ultrasonography provides comprehensive assessment of portal hypertension. Parameters such as liver size, portal vein diameter and flow, splenomegaly, ascites, collaterals, and hepatic vein damping index collectively allow accurate evaluation of presence and severity of portal hypertension. These results are consistent with previously published studies, reinforcing the role of Doppler ultrasound as a non-invasive first-line diagnostic tool for patients with portal hypertensive disorders. These are my references. Thank you.